Just a second, please. Mm, My name is Dr. Zishan. So I can see that some of the people are new. Um, just give me a second, please. Yes. So today we will discuss respiratory system, and this is one of the, you can say, bread and butter of an anesthetist. So usually the challenges which we as anesthetists face with reference to respiratory system, one of them is asthma, COPD, pneumonia. Okay, and in our part of world, as in Pakistan, India, TB is one of the disease. There are some other condition which may be asked in some of the exam, but usually it's not common. Cystic fibrosis. Uh, so my first focus, and actually one more thing is that because cardiovascular system and respiratory system are like heart and lung, they are uh, very close together. Okay, so you can say all our organs are interlinked, but respiratory system and cardiovascular system are very closely related. And whenever we are uh, um, discussing cardiovascular system, so we the effect of any cardiovascular pathology will be ultimately on respiration, and any pathology in lungs can affect the heart as well. Okay, so usually the evaluation, some of the symptoms, if we just start from symptomatology, like one of them, it will be airway, like you can say airway obstruction, or you can say in a different way, like respiratory insufficiency, or you can say breathing difficulty. Okay, so this will be either related to upper airway or lower airway. Okay, so a few days ago we discussed, day before yesterday we were discussing pediatrics, and we did discuss in detail the upper airway obstruction and differential diagnosis, foreign body, like laryngothracobronchitis. So our main focus will be towards the lower airway obstruction. Okay. So if we just consider, so the basic symptom the patient will have is cough, shortness of breath, sputum. Okay. And leading to some sounds. Either it is stridor can be there in the lower airway obstruction, but usually it is a sign of upper airway obstruction. Okay. And mainly we will have what we say wheeze or rhonchi. If we say wheeze, so wheezing is a symptom and rhonchi is a sign. Okay, and then crepitations. So usually these are the things which will be there. And of course, whenever there is shortness of breath, so shortness of breath may be accompanied by cough and sputum. Okay, and if it is maybe episodic, like what is the feature of asthma? Because a patient with asthma, this is a reactive airway disease, and the airway resistance increase, there is wheezing, and it is usually triggered by anything. Maybe it is allergic or non-allergic. Even it can be there without any allergy. Okay, so there is association with vasomotor, what we call as emotions, extremes of emotions, weather, some specific time of the day. So what is the result? Is that there is reactive airway. Okay, there is reactive airway, and then there are two things because of reaction. So whenever we are angry, we either cry, or we scream or we cry. So whenever there is scream and cry, there is cough and there is wheezing. And when we are weeping, so we have tears. So the tears of the airway is in the form of sputum. Okay, so this is just to understand what is actually occurring in asthma. Okay, So there is cough, there is wheezing, there is sputum production, because the mucus cells, the mucosa is reacting, and there is a lot of mucus production. Okay. So another thing is that it is in the expiratory flow. Okay. So there is bronchoconstriction, and it is leading to problem in expiration. Uh, Zainab, are you exam candidate? Zainab Farid, can I hear you?
Not exam candidate, Sean, just to refresh my knowledge with
Okay,
you.
okay, okay. Oh, it is you, Dr. Zainab. How are you? I can recognize your.
I am good. I am just attending your lectures, refresh my knowledge, if you don't
Okay.
mind.
No, 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 no. You are more than welcome. Rather, now you have to speak out as well. And Dr. Zainab, you, oh,
Actually,
like
I was busy in work in kitchen and then joined your Zoom
okay,
meeting just to
okay,
refresh your
okay, okay, okay. Thank you,
my
thank you.
knowledge. Thank you,
No
thank
problem.
you,
You are welcome. You are welcome.
thank you.
So, anyways, so this is how we proceed. And what happens in asthma, that asthma may be asymptomatic in the sense that it is, as I told you, that it is episodic. It is what is we called as paroxysmal. It occurs and it goes. Okay. And there will be complete reversal. And that is the difference between asthma and COPD. Because in COPD, this reversal will not be fully. There will be some element which will be there, and it is leading to then, because of stasis of secretions, there is you can say the airway tone is gone. Then there is fibrosis. So that is going towards the chronic bronchitis and emphysema. When the elastic tissue is lost, the presentation which we call as emphysema, and when uh, this one there is cough, there is sputum. So this is what is a basic difference between asthma and COPD. Okay, we will try to cover that one also, inshallah. So what will be the findings in asthma? So there is as we are discussing, that there is wheeze. If we just say that maybe ABGs, in ABGs, if we just think usually, asthmatic attack, if you gradually the severity of asthma is increased, usually how we label it is with the peak expiratory flow rate. Okay. But other investigations, we will just correlate chest X-ray may be normal. Or if it is a part of COPD, then maybe you will have some like increase in space between the ribs, and you are having the all the findings which we can have in COPD. But usually just chest X-ray may be normal. Okay. ABGs, usually it may be normal, or you can say the PCO2 will be less. Okay, because the patient is hyperventilating. So PCO2 is either normal or maybe slightly less, and rather it's a sign of impending failure if it becomes normal or it started increasing. Okay. And the one which is what is called as peak expiratory flow rate is like in the form of, like, it is just like pulmonary function test with all the this functional measurement of this vital capacity and FEE1. Okay. So this is a proper machine, and peak expiratory rate is a bedside technique. And if it is severe, this peak expiratory flow rate will tell you not only the severity and also response to the bronchodilator therapy, and also whether the patient need to be admitted in the hospital or maybe transferred to ICU or maybe needing intubation. So all these things, one of big thing which is important with reference to asthma is peak expiratory flow rate. Okay. So, and of course, the rest of the symptoms, which we all know, that patient is anxious, patient is if it is acute severe asthma or life-threatening asthma, maybe there is silent chest. Okay. And there are signs of like tachycardia, and like as I told you that in that case maybe patient can collapse anytime. Okay. So usually, this is how we monitor. So few words about the treatment. So usually the treatment of asthma is because there is a balance between, you can say, vagus nerve or parasympathetic and the sympathetic. Okay. So either you have to block the vagus or you have to increase the sympathetic activity in the lungs, because usually it is causing vasoconstriction or smooth muscle constriction, but here it's opposite effect, and there are beta 2 receptors which are causing bronchodilation. Okay, so if there is a increase parasympathetic effect, there is bronchoconstriction with increase of secretions. And if it is sympathetic, so we have to give the medications which are increasing the this doing this sympathetic mediated bronchodilation. Okay, and here maybe ipratropium is the medication which is being used in nebulization. Okay, so whether we have salbutamol or what you say terbutaline, so this is one part of it. And let me add some more pages, or I think I will pull up a new page. Just a second. Okay. So, so this is one thing. And then because it is, you can say, this, what you say, the inflammatory response is also there. So there are some medications which will be affecting, like leukotriene antagonist, that is montelukast. Okay. Then steroids. Okay, steroids are also anti-inflammatory effect. And then, like, we have allergic component, we have this clomolin sodium, which is mast cell stabilizer. Okay, so sorry. So this is how these are the medications which usually these three medications, they are not for acute attack. Okay, and their role, they are given, but their effect does not come immediately, like steroid like prednisolone, or even in the nebulized form steroids are being given, but usually they are being given for the maintenance of asthma. Okay, so leukotriene antagonist, cromolyn sodium, and the steroids. So this is how you should be thinking about. And again, that any group of medication, whenever we are studying, we should be thinking what are the anesthesia correlations. So mainly the beta 2 agonist, they can cause hypokalemia. Okay, because if you remember, we are also using it for the treatment of hyperkalemia, because they will push the potassium inside the cell, so it can cause hypokalemia. So this is one of the anesthesia correlation, and it will cause tachycardia. So tachycardia is a killer for a heart. If it is not only it increase the demand, it decrease the supply. So increase heart rate and hypokalemia, these are mainly two effects. And of course, if there is bronchoconstriction, it can create problem with the ventilation. Okay, so usually two three things why asthma is important for us. And then we will be something related to histamine. So all the medications which are releasing histamine need to be avoided, like morphine. Okay, and there are certain other medications which you need to give carefully. NSAIDs, mainly the NSAID which is responsible is aspirin. Okay, but the generally what is the it is decreasing the prostaglandin synthesis. Okay, so prostaglandins are usually responsible for the maintenance of this bronchodilation. So if it is inhibited, these prostaglandins, so it can trigger the, you can say, the response of this bronchoconstriction. So it's not absolute contraindication to give NSAIDs, but usually it should be given with caution, because it can trigger a. But if you say that it's absolutely contraindication, so I don't think so. It's an absolute contraindication to use NSAIDs. But usually, traditionally, we try to just give it with caution, and you always have the risk versus benefit. So you should be knowing what are the medications which are histamine releasing. So some other medications will be atracurium. Okay. So atracurium, so cis-atracurium is a better choice because it's not associated with the release of histamine. Okay. So cis-atracurium will be a better choice, and you have to avoid anything which can trigger the bronchospasm, like light plane of anesthesia. Okay. And medications like, for example, thiopentone. So thiopentone and ketamine, traditionally it is said that it causes bronchodilation, but actually it increases the secretions as well. Number one, this is which is not good. And another thing about ketamine is that ketamine does not blunt the airway reflexes. So these two things can precipitate the attack of asthma, or you can say bronchoconstriction. So ketamine and this thiopentone. So propofol is a better choice because it blunts the airway reflexes. So among the induction medication, propofol is a better choice as compared to thiopentone or this ketamine. Similarly, fentanyl can be given. Like opioids are usually safe. Only morphine is associated with the histamine release. And then the rest of the things, again, the reversal, neostigmine with atropine, usually, neostigmine with the glycopyrrolate, it can be given. But the problem is that though we give it in a combination, but still it can increase the secretions. So it can also precipitate. And as I told you, that neostigmine glycopyrrolate combination can cause tachycardia as well, like any reversal. Okay. So you should be just considering this thing that if you have given nebulization, the patient already is tachycardic, and now you are doing this. So maybe the option will be that either you avoid muscle relaxation. If you are doing any surgery in which muscle relaxation can be avoided, this is number one. Number two, if you are using cis-atracurium, maybe you don't need to give reversal. Okay, so this is number two. Or you can use rocuronium to be reversed with sugammadex. So when you are discussing in Viva, you can just speak out in this way, but it is not contraindicated. Okay. Again, the fluid management is like a normal. So usually you should give a multimodal analgesia, and you should be avoiding any trigger which can cause bronchospasm. This is one thing. Another thing is something about the ventilatory strategies. Usually, as I told you, that it has problem with expiration. Usually, you don't need too much, but maybe if you are using pressure control, you can monitor the airway pressures in a better way. This is like you can control the airway pressures and then you can have better curves for the ventilation. This is one thing. And like expiratory time, maybe you need to prolong a little bit at times if it is causing a problem. And intraoperatively, then they ask another question, which is also common. One is that differential diagnosis of uh, what is the message? So, anaphylaxis is something else. Anaphylaxis is something else, or any medication can cause anaphylaxis. Okay, so it doesn't mean that we cannot use it. Sugammadex anaphylaxis, how frequent it is, how like what is the prevalence of Sugammadex anaphylaxis? Then any medication can cause. So rocuronium can cause anaphylaxis. So anaphylaxis is something else. Okay. This allergic response is something, allergy is something else. Anaphylaxis is a very severe form of allergy. So that's something else. You're right. But remember one thing, rather to be very specific, the anesthesia medication, the result is anaphylactoid reactions. Okay. And because there is difference between, because it's not IgE mediated, that one is IgE mediated. So usually they cause anesthesia medication. It's themselves like prove like are they are behaving like a allergen. Okay, so that is how you have to differentiate. So okay, so actually this is how you can just have, what is the message? Yes. On the professional forum, it is always better to put your name rather than you see doctor, iPhone, like, professional forum, it is better to keep your name. It looks more professional. Okay. Anyways, so uh, I just wanted to show you something. Just a second. Sorry, this is I think in the start of the chapter because what the effects which are there in asthma is on FE1. Okay, so FE1 is decreased. Rather, this is the differentiating point between obstructive and restrictive disease pattern. Okay, yes. Okay, so flow volume loops. We will just have few words about it. So this is the normal curve of this FE1 and FVC. And in obstructive, you see FE1 is reduced. Okay. So in first, second, forced expiratory volume. So this is the concept of this FE1 over FVC ratios. It is gradually getting less and less. So it is severity of more is more. And restrictive, because usually FVC is reduced much more, or you can say both are reduced, but FVC is reduced much more than FE1. Okay, so this is one thing, and here also that this is the normal flow volume loops, and this is the tidal volume. This is inspiratory reserve volume. Okay, and this is FRC. Usually in especially COPD, this FRC is increased. We will just show you. I will just show you in the flow volume loops as well. So this is the residual volume total. This is another question which is being asked a number of times, that what are the volumes, what are the capacities which are not measured in the normal spirometry. So actually, because residual any capacity in which residual volume is included cannot be measured, because residual volume cannot be measured. There are specific method, nitrogen washout and helium dilution method, I think, for the measurement this one. But usually, vital capacity vital capacity can be measured, but not FRC. Okay. And also total lung capacity cannot be measured. So this is another thing which you should be knowing. Okay. So we will have a few words about this. You see, now how this, actually in this book, they have explained. Okay. Usually in a number of books, you will see residual volume part on this side, but in this book, they have made it in a slightly different way. So normally this is a volume which is remained. Okay. And when we inspire, the flow rate is in minus, we are taking inside. Okay. And then it is coming out. So this is a normal curve. Okay, usually expiration is prolonged and as compared to inspiration. So it is how it goes. Okay. So now we will just have an obstruction. What happened? Because inspiratory time will be the same. So here, if you compare these two graphs, okay, so you will see that this point of residual volume is pushed to the left. Okay, so there is more residual volume as occur in COPD. So there is more volume of air which is there inside because of air trapping, because of the way patient not able to expire properly. Okay, so this is, you can say that here the dot was maybe here to start with, and now it has pushed to this side, so this part is increased. Okay, the inspiratory portion is the same, but because there is problem in the expiration, so expiration flow is decreased. So there you can say that in this is the inspiratory, this is the expiratory. So expiratory portion is disturbed. Okay. Okay. So in restrictive, you see how they have made it so residual volume is the same, but volumes are reduced. So a TLC is significantly decreased. Okay. The rest of the graph is almost the same, but you see this one, the total lung capacity was like this, and it you see it has decreased so much. So instead of here, it has gone to here. Okay. So this is you can see in the restrictive disease, and this variable intrathoracic and extrathoracic. This is slightly different. That in intrathoracic problem, expiration will have problem. Okay. So you can see that intrathoracic lesions, see, intrathoracic obstruction is more likely to allow gas flow during inspiration. Okay. So as a negative intrathoracic pressure generated helps to pull the airways open. So in such, inspiratory limb of the curve may be near normal. In contrast, the positive pressure generated during a forward expiration serve only to exacerbate the obstruction. Okay, and such the expiratory limb appears similar to that seen in obstructive disease. So this is how it presents. Okay, so intrathoracic problem will be in the expiration, and in extrathoracic, like occurring in the above the you can say trachea, so that is extrathoracic obstruction. So they are causing problem in the inspiratory side. An extrathoracic obstruction is more likely to allow gas flow during expiration, as the positive pressure generated during this phase acts to force the airway open. Okay, so it is from the this portion the air is pushed out. So expiration phase is normal, and inspiratory phase is the problem. Okay, so negative pressure generated in the airway during inspiration serves to collapse the airway further. That's why there will be problem in the, because now there is negative pressure. In expiration, positive pressure is generated, so it somehow is pulling out. So the expiratory phase is normal and inspiratory falls, and this is the fixed. Okay, so you can say in which both phases are disturbed. So in this book, it's explained in a much better way. Okay, so we will just uh, have some more look about it. Actually, my main focus was that how to assess the respiratory system. So there is another test which is being used. What is uh, just a second. I think we will discuss this in thoracic. Just wait for a while. Uh, so we discussed today asthma. Uh, yes, one thing I just actually I forgot at that time. What is the differential diagnosis of intraoperative bronchospasm? Okay, so because it may be because of pneumothorax, it may be because of pulmonary embolism. These are serious things. Otherwise, it may be related to tube kinking, inadequate anesthesia, inadequate muscle relaxation. Okay, and any anaphylaxis may present as any allergic reaction. It can present with the high peak expiratory, peak expiratory, sorry, peak airway pressures. So this is just uh, how to manage. What is the differential diagnosis and how to manage? So usually we shift it to 100%, ventilate with hand. We see that anything of course at this time you also have to call for help. So call for help, stop the surgeon, inform, and then you can step by step. Maybe you when you convert into manual, you will see that patient is breathing. So you might need to give muscle relaxation. Okay. You might need to give depth of anesthesia is decreased. So this is one thing. Tube touching the carina. Sometime it can also cause, or if it is becoming endobronchial. So this is also can cause airway increase in airway pressure. So you will just this thing, and you will see whether you have started anything which is causing like antibiotic, blood transfusion, or if you are using any muscle relaxant which is causing. So if you have given and well, rash is not mandatory. Rash is not mandatory. Sometimes if someone asks that what is the most reliable sign of anaphylaxis or allergic reaction during the anesthesia, so it may be either hemodynamic collapse or airway obstruction, this increased airway pressures. So you have to rule out whenever it is occurring. So you will do the step by step management. You will do some suction. You will just try to see what is anything reversible, and then you will go step by step. Okay. So deepen the anesthesia is again, if ventilation through endotracheal tube impossible, check the tube position and exclude blocked or displaced tube. And if necessary, eliminate breathing circuit occlusion by using self-inflating bag. In non-intubated patients, exclude laryngospasm and consider aspiration if possible. Like maybe patient can have aspiration. So in non-intubated patients. So I think this is how you will proceed, and then the you can give some steroid. You can nebulize with the meter dose through the endotracheal tube because we are discussing intraoperative. Okay, so intraoperative majority cases will be either like intubated or non-intubated. So slightly different things will be there, but usually these are the different options which you will be using. Okay, maybe you need to have epinephrine if there is a problem of anaphylaxis, and rest of the thing, magnesium, ipratropium. Here it is not written because the last resort will be ECMO or nitric oxide. This will be the last resorts for such condition. Okay. So anyone wants to ask any question? Any question? So inshallah we will continue our discussion because I wanted to discuss COPD today, but I think it will take more time. So tomorrow, inshallah, we will continue our discussion. Okay. So thank you very much. Bye bye.